Thank you. Okay, we're going to move on. We're going to move to building a strong research and evidence base for public policy and violence prevention. And we have Alexander Butchart from the World Health Organization. He's the coordinator of the violence prevention, violence and injury prevention.
Okay, thanks. Andres was just priming me on how to use the forward and backward button. Thanks very much for this invitation to come and speak at the National Academies on this topic. It's especially exciting for me to be back here. I was at the first meeting in 2007 when we discussed violence prevention in low and middle income countries, at which point the idea of a forum was first floated. So it's great to be back. Thank you. What I thought I'd do in my time is to continue where Andres left off and provide some grist, I hope, for George's mill by taking stock of what we have by way of research and evidence for violence prevention policy making, and what I think we need in order to become more effective. Just to very briefly set the scene, I'll look at developments since 2002 and 2003, when the World Report on Violence and Health was published, and an associated World Health Assembly resolution on implementing its recommendations was adopted. The report distinguished between self-directed, interpersonal, and collective violence, and highlighted their significance as causes of death and as contributors to health and other social consequences. I'm really happy that Jerry Reed from EDC is here, because he is going to be talking about self-directed violence, which I'm not going to cover. I'm going to focus exclusively on interpersonal violence. I don't think we have anybody in this meeting today looking at the collective violence, but that's a very different kettle of fish. So perhaps it's appropriate that we limit this discussion to the self-directed and the interpersonal bits. In 2012, there were an estimated 1.4 million deaths due to all forms of violence in the world, equivalent to 2.5% of global mortality. Suicide, self-directed violence, accounted for over half of this, 56%. Interpersonal violence or homicide, 36%. And collective violence, 8%. Collective violence may have ticked up to about 11% if you look at this estimate for 2014, but it never, in the time that I've looked at the global burden of disease estimates, it's never exceeded about 12% of the global burden of death. Of course, and we all know this, but it's really important to reiterate it, especially when you are talking to policymakers and you are talking about forms of violence that are not homicidal or suicidal, but non-fatal violence. Death is only the famous tip of the iceberg, and it's overshadowed by often broader, lifelong health consequences, which include, maybe you can't all read it on these slides, it includes various forms of injuries and resulting disabilities. It includes non-communicable diseases, such as diabetes, obesity, cancer, etc., which arise due to risk behaviors like the abuse of alcohol and drugs, smoking, unsafe sexual practices. It includes HIV/AIDS. It includes maternal and child health problems, such as unintended and adolescent pregnancy complications, a whole raft of mental health problems, some of which can lead to suicide. So interpersonal violence, particular child abuse, is a big risk factor for self-directed violence. Violence begets violence, and being a victim of violence or witnessing violence can lead one to be more at risk to be a victim or perpetrator of assault of violence, and so forth. So how has global violence prevention evidence and information for policymakers progressed since 2003? My answers to this question are going to be roughly organized around each of the 4 stages of the public health approach to prevention, which are defining the problem using descriptive statistics, identifying underlying causes and risk factors, although they have mixed it up with consequences as well, establishing what works to prevent violence through outcome evaluation studies, and scaling up policies and programs that are effective. Starting with data collection to define the problem. I think there's been good growth in the number of countries that have completed nationally representative surveys of violence against children and against women. For instance, since 2007, Together for Girls, CDC, and UNICEF's Violence Against Children survey has been completed in 13 countries and is underway in another 10. There's also been a lot more prevalent studies of violence against women, which have permitted the computation of global and regional estimates of prevalence. This is good progress, but it doesn't mean we have to take our foot off the gas. We've got to continue to push this, because compared to other issues, other health conditions, there's only a handful of studies. So I don't want this to be a message that we've done enough. No. We've got to continue with that progress, but we've really got to pick things up when it comes to measuring violence-related deaths. As it stands, fully 60% of the world's countries lack adequate vital registration data to count and define the nature of death, including homicides. So they cannot tell you the who, what, when, how of homicides in 60% of the world's countries. They may have a smattering of criminal justice data, but it's very difficult to ascertain the completeness of that, and it usually lacks anything like the detail of civil or vital registration data. The collection of information about violence among men is also something that has not been prioritized, and we know very little about the prevalence of that. Youth violence in general, we've got some decent studies such as the Global Schools-Based Health Survey, which look at bullying. We've got a handful of studies which look at dating violence. Of course, that is included in the Violence Against Children surveys, but youth violence is somewhat lacking. Elder maltreatment, hugely neglected. We have barely any knowledge at all about the prevalence of violence towards older people outside of 1 or 2 or 3 high-income countries. And given the growing number of elderly, that's a really huge gap. And then multiple types of violence. We keep perpetuating the idea through the fact that we only study, for instance, child abuse or violence against, we study things separately, child abuse, violence against women, youth violence. These things often occur together. They come in packages. And we need to be able to start looking at so-called poly-victimization, or how multiple types of violence cluster, how one individual may be at risk for several types of violence, how in one family group multiple types of violence will co-occur, because that has huge import for our understanding of prevention. In terms of research on risk factors and consequences, which I've put together in my version of the public health model, because the consequences are often risk factors for subsequent perpetration or victimization, we've come a huge long way in terms of understanding the biological aspects, especially with the new ability to do neuroimaging and looking at the brain as it is working and understanding how the impacts of violence can become hardwired. We've got a huge lot more information about long-term health and behavioral effects, in particular of violence against children and women. There are more and more strong longitudinal studies which help us to see cause and effect, but also help us to understand that cross-sectional studies are indeed not as weak as some people make them out to be. They are, in fact, things like the adverse childhood experiences studies. They stand up quite well when you compare them to findings from longitudinal studies. And we've got more schools-based surveys, which is a good thing. Once again, this is not a message to stop doing it. We need to do more of that. However, here we also have important gaps. When we look at violence against males, it is usually seen and understood in very reductive sense as purely leading to physical injuries. Compared to violence against women or children, which of course includes boys, but I'm thinking of adolescent and adult males, violence against them is not seen to have as many psychiatric, psychological, social, or non-injury health consequences because it hasn't been studied for those, and it should be. We have much less research on the consequences and the risk factors in low and middle income countries, although of course the violence against children surveys are helping us, but there may be some specific risk factors in those settings which we haven't unpacked yet. What about out-of-school children and youth? A huge issue. They are surely at higher risk than kids in school, yet we barely monitor them. We know very little about multiple levels of risk, individual, family, community, and societal. We have some great studies from wealthy countries with all the data, and you can do hierarchical analyses, etc., but very little about that in developing countries. And we've talked about the economic costs of the consequences. We have very little about that outside of a handful of wealthy countries. In terms of research on prevention, and here I'm talking about a very simple, concrete measure, the number of published outcome evaluation studies that look at the prevention of child abuse, intimate partner violence, youth violence, etc. We see that the evidence base is growing quite well over the period I've shown here, which is from 2007 to 2014. And each year, the number of studies across that period has grown from around 40 to nearly 70 in 2014. So that's good. It seems to suggest that there is a continuing interest in understanding what works and so forth. But when you look at the geographical distribution of that evidence base, of where those studies are coming from, we see the familiar imbalance, the geographical crowding of studies from North America. And very little, in fact, from anywhere else. But it is good to note that sub-Saharan Africa is on the map, and if this map were to be updated today, Kenya, Tanzania, and Uganda would all light up, and that's brilliant. That's because of the effort being put in there to address violence against children because of its prominence as a risk factor for HIV/AIDS. While no or few studies on prevention effectiveness from any region is bad news, I think the fact that there are so few from Central and South America is especially notable, given the very high levels of violence in that region. And Rodrigo, sorry, this slide does not include your and Andres' study because it came before this, but I recognize them for their groundbreaking things. So it's doable. It's quite eminently doable to do these outcome evaluation studies in highly homicidal contexts. We need to get them done. By type of violence and prevention program, growth has been good in the number of studies on child maltreatment prevention, youth violence prevention, and intimate partner violence, and around individual and family-focused programs. Once again, this is not cause to take the foot off the gas. We need more, but there's been growth here. However, on sexual violence in general and elder abuse, the number of studies has not been growing as fast as for the previous 4 types. Prevention outcome evaluation studies that look at the impact of a program, for instance, on alcohol reduction or alcohol abuse reduction on multiple types of violence. We have very few such outcome evaluation studies, yet theoretically there are a number of interventions we can imagine should have a broad impact on several types of violence, including self-directed violence. We need those studies. Because they're more difficult, community and societal interventions are fewer, and we have very few cost and cost effectiveness in particular studies. So, while studies on the prevalence, the causes, and the preventability of violence are increasing, efforts to document the extent to which countries are making use of scientific knowledge to scale up violence prevention and provide services for victims are just beginning. The Global Status Report on Violence Prevention that WHO put out a couple of years back with UNODC and the United Nations Development Programme is one of few efforts to do this, and it describes the extent to which countries are putting in place evidence-based programming and policy making in relation to prevention and to victim service provision. And the findings offer an opportunity for violence prevention stakeholders to understand the extent to which there is more potential for more prevention. This slide, you probably can't read it, but in summary, it says that just 1/3 of countries are doing scaled up work to implement the kind of prevention programs shown here. And if we go by income status, then the proportion of countries drops way down to about between 15 and 20% that say they have scaled up things such as life skills training or parenting interventions, etc. So really, that means the potential for more preventive action is huge. So there's been substantial, if patchy, progress in the global violence prevention field since 2003. And this has certainly contributed to opening up new horizons for prevention and led, I think, to new needs and opportunities in terms of research and evidence and in terms of advocacy. So in identifying these, I'm going to focus on 4 new platforms for implementation action, and they provide all of us with the tools we can use to advocate for increased investment. And they are the Sustainable Development Goals, the Global Partnership to End Violence Against Children, the Inspire Technical Package for Ending Violence Against Children, and WHO's new Global Plan of Action on Violence Prevention. As we all know, the Sustainable Development Goals replaced the Millennium Development Goals and define priorities for development from now until 2030. The Millennium Development Goals were silent on the topic of violence prevention, whereas the Sustainable Development Goals include targets for ending violence against women and children and significantly reducing the proportion or the number of deaths due to all forms of violence. And these targets, for the first time, put violence prevention very squarely on the development map. Of course, several other goals, for instance, those around poverty, inequality, early childhood development and education, and so forth, are really important insofar as they address many of the risk factors for violence prevention at both a structural level, community level, and at a family level, and even at the individual level of brain development. So research on how efforts to achieve these other goals may be influencing violence would be useful. To assist countries in achieving the Sustainable Development Target of ending violence against children, the Global Partnership to End Violence Against Children was launched in July this year by Ban Ki-moon in New York. And the goal of this partnership is to harness the expertise of partners in prevention and support national and local level work to scale up strategies that effectively put in place programs to prevent violence, provide services for victims, and importantly, monitor their uptake and their effectiveness so as to expand the evidence base. Central to the partnership's work is a new technical package that several organizations represented in this room contributed to, and it's called Inspire, 7 Strategies for Ending Violence Against Children. And this has been signed off by no fewer than 10 important global agencies, sending a very strong message to readers and to audiences at local and national level about the importance that these agencies give to preventing violence against children. And you can see the agencies listed there. What the package does is to distill the best available evidence to help countries intensify their focus on implementing effective programs to prevent violence against children and reduce its consequences. I won't spend too long on this, but it's important to know that the letters of the word Inspire stand for 7 strategies, and they are implementing and enforcing laws, norms and values, safe environments, parent and caregiver support, income and economic strengthening, response services, and education and life skills. I wanted to say that because this year in October, the special issue of The Lancet was published, which focused upon the presentation of a framework to promote young children's development through a multi-sectoral approach. This is the famous shift from surviving, child survival, to thriving, to ensuring that kids don't just live until their 4th or 5th birthday, but that they go on to thrive and become the absolutely healthiest individuals, most pro-social individuals possible. And what's really exciting about this new drive, which we hope will translate into policy and funding, is that Inspire maps really well onto most of it. So we can see the different parts of Inspire represented well here: implementation and enforcement of laws, norms and values, safe environments, parent and caregiver support, income strengthening, etc., etc. So I really recommend that if we are thinking about advocacy and trying to promote the uptake of violence prevention, this is an important window that we should be drawing attention to, because the connection between early childhood development and violence prevention is very rich. And indeed, as Jack Shonkoff in a commentary on this issue noted, systems to use all available evidence productively are essential for transforming the lives of millions of children. And I think that's a great call for what I consider that a great call for more implementation research. And that's really an area where we need to go far in understanding how we can move from an excellent trial of a program at a relatively small scale to putting that program out there at a large scale so that it will reach hundreds of thousands of families, for instance. So within the health sector, I mentioned briefly the World Health Assembly this time, for the first time ever in May 2016, adopted a resolution endorsing a global plan of action on the role of the health sector to prevent and respond to violence, a really important development insofar as the health sector is perhaps the major missing sector in many countries when it comes to preventing and responding to violence, despite the fact that it is obviously one of the sectors that carries the greatest burden in terms of the consequences and has a very clear role in terms of prevention. The plan covers violence against women and girls, violence against children, and all forms of interpersonal violence. So I'm going to end now by giving my kind of diagnosis about what we need to do by way of getting the evidence balance right so that we can more effectively promote violence prevention. There are a couple of balances that I think are implicit in what I've said, but I'll now make them explicit. And the first is between research in high-income and low- and middle-income countries. Quite clearly, the bulk of evidence for prevention is still coming from high-income settings where the prevalence tends to be lower, although that is no excuse not to do prevention, of course. But we need far more evidence from low- and middle-income countries to convince policymakers in those settings that this stuff works there. So the balance should look something like that. And it is moving in that direction, but it needs to move faster in that direction. We need to do a huge amount of work on getting the balance right between measuring problems and prevention. I think we've done extremely well in showing the consequences of violence, the long-term health consequences, etc. But we've, in a sense, created a David and Goliath situation where we've got this enormous problem which has consequences across the lifespan, and we've got these puny little interventions to call. We've got 653 studies to draw on. My goodness, is that the best we can do? We need to do more research on making evidence-based prevention and response measurable and visible, because it is happening in many places. It needs to happen much more, but if we can show that even however inadequately governments and civil society are investing in prevention, it will help to, I think, increase momentum and investment in prevention. We need to get the balance right between individual and family interventions and community and societal strategies. Probably this is mainly in terms of evaluating their impacts. It's understandable that our focus so far is on individual and family level interventions because they're easier, not easy, easier to measure their impact. It's much more difficult to measure the impact on a community of, for instance, efforts to reduce inequality between parts of a city or to allow people greater movement between rich and poor areas than it is to measure the impact of a family-based intervention. And it's even more difficult to measure, for instance, the impact of gun laws at a societal level in a society where you may not have good homicide data. So we need to get that balance right. Ultimately, community and societal strategies are likely to be far more effective in reducing multiple types of violence at the same time. We need really to get also the balance right between women and girls and boys and men. Boys and men are the perpetrators of most types of interpersonal violence and are at many times higher risk of homicide than girls and women. They should therefore be the primary targets for intervention. However, even WHO's own Global Plan of Action and many other UN documents stop short of condemning the acceptability of violence against boys and men and relegates their involvement to promoting gender equality and empowering women and girls, which is obviously a really good thing. And therefore, without undermining men's continuing role in doing that, global violence prevention efforts are likely to make far more headway if we get a proper balance of preventive attention between both sexes. In terms of older people, it's estimated that globally there are around 140 million people over 60 years of age that are abused, and efforts to prevent elder abuse are pitifully few. So it's really important that we get a better age balance in place. And then Well, lastly, research has shown how different forms of violence often co-occur. One type of violence can cause another, and there are several shared underlying risk factors. And despite this, the bulk of prevention work focuses, or at least outcome evaluation studies, focus on targeting single types of violence in isolation from one another. For instance, intimate partner violence in isolation from child abuse, or child abuse prevention in isolation from youth violence and bullying. We need to recognize that there are specificities to certain individual types of violence, for sure, and we therefore do need specific interventions for them. But we should balance that by more efforts to understand the impact of programs on multiple types of violence and in designing programs that can address multiple types of violence. So I'd like to end by saying that I think the next big advances in prevention are going to entail a stronger emphasis on implementing evidence-based prevention programming and policy. Platforms to do this exist, but we need a better balance on several dimensions, which I've outlined, if we are to reap the benefits of that for global violence prevention. Thanks.
Thank you. Again, any clarification questions before we move on? Yes.
Yeah, thank you very much. That was an excellent presentation, and both presentations have been very interesting. I have a clarification, which is, I'm curious, you talked about the use of evidence and how, I think you said something like maybe about 30% of countries, I may have misunderstood. I'm curious how that was measured. How did you measure whether countries were using evidence-based? Thank you.
Oh, it's a good question. We asked countries to put together a multi-sectoral panel in each country, and we had them answer a set of questions relative to definitions of what we defined as evidence-based programs. So this was a rather subjective measure, which is utterly prone to bias on the part of the reporting by the countries. Wherever we could, we cross-checked that against information from other sources on a country, but it's one of the most difficult things out there to measure the extent of evidence-based programming. We will be repeating the Global Status Report in a couple of years' time, and one of the things we'd really want to work hard on and look forward to getting advice from as many people as possible on is how to more objectively measure the extent of evidence-based programming and policy uptake. It's very difficult, and it's something that plagues all of WHO's status reports. What we've done in some other areas when it comes to law is we hire an army of lawyers to trawl through national legal stuff on, for instance, tobacco or road safety, and analyze the quality of those laws in terms of their enforceability, et cetera, et cetera. We don't yet have those resources. We'd like to get to some point like that.